All right, I'm going to share my screen. So do you have any specific questions, or you just want me to go over the things that I find you should be knowing? Any specifics? Nothing?
Oh, I do have a question about PVD.
Okay.
So when I was
Question about PVD, PAD?
Yeah, when I was reading the book and comparing it to your slides, the book mentions about like specific about PAD, but there is like arteriosclerosis, which is like almost the same as PVD. But so what I'm asking is, are they the same?
So they're caused by the same problem. Arteriosclerosis is the fatty plaque that builds up in the lining of the veins and arteries. So in that sense, they're similar, but the arteries are the ones with the sclerosis plaque, whereas the, what is it called? The veins, their problem is not necessarily the plaque, but it's the valve that's a problem.
So it's like the same.
It's not the same. The only way it's similar is in the fact that we have insufficiency. We have a problem. We have like issues with injury. If there's a cut, they can't heal properly. Those are the similarities. But the reasons behind why the issues happen is mostly arteries, is because of the plaque that's building in the lining. And valvular issue is because the valves are not working properly, because the arteries and the veins work differently. So arteries build a plaque causing occlusion. Valves, veins, the valves are not closing properly, so they're not pushing the blood back to the heart. And so blood is remaining where it shouldn't be. So
kind of like CVI, no, because when you said remaining where it shouldn't be, because with CVI, it's not able to like have that return of the blood flow because of.
Yeah. Okay. Define CVI for me.
So what I was thinking, like, when you, for example, when you stand for a long period of time, that's like one of the causes, or that's something that could happen when you stand up, like, I think there's like, your blood is, you're not able to have like return of blood, and so like you'll have like old blood accumulating
right
in the lower legs, and so like of course you'll have like discoloration.
Yep. So that's the valve issue.
Okay.
Yeah. Whereas the arteries, they're not getting to the legs. The blood is not getting to the legs. Okay. All right. Any other questions? Okay, so then let's just go over. So for the physiological aspects of the heart, you need to know how the heart pumps blood. So knowing about the right atrium, left ventricles, the different valves, where they lead to, right? The right side goes to the lungs, left side goes to the body. So you have to know the anatomy, okay? That's important. Understanding the circulation behind how arteries work and how veins work, or how they get, the blood is transferred from vein to artery is not really a concept that I'm testing on, but that notion is important. You have to understand the concept of cardiac output, what it means, heart rate, stroke volume, but especially cardiac output, because that is specific to, if the heart's not working well, we know we're going to have a reduction. So you need to understand what that means, right? If you're not getting enough blood to pump out, it's not going to get to the blood, to the brain. It's not going to get to the extremities. So that's going to be a problem. So understanding what that means is important. Remembering what preload is and afterload is. is important. We know preload is before, so it's the filling, how much volume we have before the contractions happen, that's preload. And afterload is the tension that has to be applied for the contraction to occur. So how much force has to be applied to the smooth muscle in order to push the fluid out. So you have to remember preload, afterload, understand contractility, understand heart rate. The conduction part, you have to remember the SA node and what part of the body it signals, or when I say part of the body, part of the heart that it signals, the AV node, what part of the heart it signals, like the order of it. SA node is first, V node is first, then the bundle of His, then the Purkinje's fibers. So kind of understanding where they're located and what they're stimulating. The action potential, calcium, sodium, that's a good to know concept, but it helps you understand when you give medications, why you're giving certain kinds of medications. So that's a good to know portion. PQRST, you have to know what those are, especially the P, what it represents, atrial contraction, atrial depolarization, where if it's atrial, then it's coming from the SA node, starting from there. You have to understand QRST, it's talking about the ventricles, ventricular contraction, ventricular depolarization, and the T is ventricular repolarization. So understanding what they represent is important. Learning about the PR, the ST, it's good to know information. It helps you kind of conceptualize in between what is happening. Knowing how to measure EKGs is a good concept to understand. We're not going to need the boxes per se, but if you need it, you have to understand how it works. But if you just look at it and are able to identify it, I think it's great because there's less work for you. Looking at the EKG and recognizing, oh, this is asystole, this is AFib, this is V-Tac, right? Just looking at it and trying to remember what it looks like is easier. But if you cannot, then knowing that each box is 0.5, each small little box is 0.5, 5 boxes are 0.20 seconds long, and they're 5 millimeters. Like those things are important to know if you're not able to identify it visually. So the measurements for yep.
Is that to determine the heart rate?
That is to, so if you're asked the heart rate, yes, it can help you determine the heart rate, but the measurements will help you identify which arrhythmia you're looking at. Yeah. So we remember PR interval is from 0.12 to 0.20. QRS is 0.08 to 0.10. Those points are measured by the box, right? And so if you have a specific, let's say where your QRS is wider, then we know that is usually a problem with the ventricles. And so we can identify it with our eyes, but we can also identify it with the measurement. So the measurement can tell you what you're looking at, which rhythm the person is in.
So it's either just looking at it and tell what it is, or like measure.
Yeah, so if you can't just look at it and tell what it is by memory, you can measure it, and those measurements will tell you. And when we kind of covered it, we'll go into it really quickly. So remembering the risk factors of how people might, or why people might get dysrhythmias, remembering the laboratory values that you should be thinking of if you take note of them. Obviously, if it's a heart issue, cholesterol, fat, triglyceride, all of those things can cause a buildup of plaque and atherosclerosis. Like, so that matters. It makes sense. Troponin is one of the ones that are specific to the heart. So you want to be able to realize that. The numbers are not as pertinent for us now, but identifying it. But if you do know the number, it's going to help you in the future, right? So more on diagnostics, cardiac catheterization, that's one big one to recognize, cardiac catheterization. So if a person has occlusions or issues with ischemia, pain, whatever, they're going to want to identify how much it's of the coronary artery is occluded, what the problem is, where the problem is. So they're going to do that. Also trying to identify where it is would help us with the X-ray, the MRI, the CT, the PET scan. But I think the EKG is definitely something that you need to remember. The reasons behind cardiac catheterization is definitely something you have to remember. The others, good to know. The numbers also, very good to know, to identify what's normal, what's not. So when it's mentioned, you're like, oh, this person has a problem. Okay, even if I don't ask you what the numbers are, you should know what they mean. Okay, yeah.
What would you ask us if you're to get us a script? Like,
I can't tell you that. That's something you have to just, you had a practice, right? And so you have to be able to identify it.
So would you say the question would be similar to
you have to be able to identify it. That's all I could tell you. Yeah. So the homework helped you identify what it was, right? So I'm sorry, like I can't, you know. Yeah. Yeah, the homework is just to help you identify what it is. And so if you were able to do the homework, then when you look at one, you would either be able to visually identify what it is, or you would use the measurements to identify what it is. But then obviously just knowing what it is not all. I need to know if a person is in this arrhythmia, what am I going to do? Like, oh, you're in AFib, good job, right? No, we're nurses. Once we identify, we find solutions. So yeah, you're going to be able to identify it, and you also have to know how to treat it. So.
And then also, what about causes?
As you said, it was like good to know, but it's still on the slide.
Right. So when I mentioned good to know, so remember when this learning is a part of a preparation for Nclex. There are things that I will test you on, and there are things I can't test you on everything. But there's a lot of things that I cannot test, that I won't test you on, that is extremely important for you to know. So the things that are good to know are really good to know. And sometimes if you don't know them, you won't be able to understand the things that you must know. If you understand what I mean, right? So the things that you must know, I say that because I want you to be able to feel like, okay, this is extremely important. And like, you won't be a good nurse if you can't know, if you don't know the things you must know, right? But you also need a background in order to help gear you towards that direction, right? So you need to understand why a person gets into an arrhythmia, right? Because when you're doing the history, that'll help you realize, oh, this is what we're gonna work on. And these are the teachings I'm gonna have to give you, right? So it is good to know that. So the waveforms, we said we had to remember what the P, the QRS, and the T stand for. The idea of the refractory period, good to know, so that we know, like, okay, they're not supposed to get any stimuli within a different area, right? Outside the area where it should come in. The EKG or ECG boxes, also good to know, especially if you're not able to identify it just by looking at it. Determining the rate, the numbers will again help you identify. But again, like I said, if you're able to, even the measurement, what is it? The rule of 300, rule of 1500. It's good to know if you can identify it, right? But if you can't, then you must know it because that's what you need in order to identify it. But again, like if you could just look at it, why do you want to do the measurements, right? It takes time.
Question about the rule. So on the forward, there was one question where we had to use the rule of 1500 instead of 300. Why we would use the 1500 instead.
So the 300 is a little bit more it's like guesstimating, whereas the 1500 is more specific, where it'll tell you exactly what the rate is, whereas the other one, it gives you an average. So if they want a specific number, yeah, you're going to use the 1500 rule. But if they wanted a guesstimation just about, then it's good enough for the 300 rule. So that's the difference, really. So normal sinus rhythm, you have to be able to identify that so that you know when it's not, right? That's important. Sinus brady, knowing what it looks like, you have to know what it looks like, and you have to know you must know the treatment. And the biggest treatment we have is IV. What is it? Atropine, right? So that's you definitely need to know that. Also realizing that if a person's asymptomatic for any of them, usually just monitor them and don't do any intervention per se. So taking note of that. Sinus tachycardia, looking at it, you should see it's the R waves are so close together, but you still have a Qrs. So that's why it's normal and regular, but it's just faster. Usually resolves on its own. There's no treatment per se, but like according to whatever has caused it, that's what we're treating. And that's why it's good to know what caused it so that we can fix it, right? The next one is atrial arrhythmia. So specifically to the atria. So we have PAC, and all that is just the P wave is sooner than it should. So the whole PQRST happened a little bit before it was supposed to. So once you see a couple of them that are regular, a distance away from each other, and then one that's a little sooner than it should, that should signal you to realizing it. If you know the measurements, then you can also identify what it is as well. The treatment, if it's infrequent, it doesn't happen often, you let it be, just monitor. But if it is frequent, then you want to use medication, treat the underlying cause, beta blockers, calcium channel blockers. If there's a lot of them, you want to use amiodarone. PAT, paroxysmal atrial tachycardia, supraventricular, also have issues there as well. Knowing that you use adenosine, even if the person is stable, which is a little different from what we've seen in the past, right? We usually don't do anything when they're stable, but in this one, we do something. And when they're unstable, we cardiovert them. Okay, so that's something to note that's different. I always mention to you, when you're studying, take note of what's different so that it can help you remember. So they take the adenosine, okay? Atrial flutter, we know the biggest problem we'll see in between the QRS is fine, but in between where the P is, you're gonna see multiple Ps, and then Ps are gonna run into the Ts, right? So it'll just be jagged saw or butterfly wing shape, whatever you wanna call it. So you definitely have to be able to identify it, and you have to know what to do for it if it's unstable, if it's, whatever treatment that you have to do, you have to remember that. So that's atrial flutter. Also, knowing about the, fibrillation is the one that you worry most about, clotting, right? Because it's not beating as it should. So that means it's sitting there and not doing much, and that can cause clotting. So atrial fibrillation, noticing that atrial flutter is not as bad as atrial fibrillation. So knowing what to do as a consequence. If it's unstable, you cardiovert. If it's stable, you give anticoagulants, and you allow it time to convert back into normal rhythm.
So sorry, I have a question.
Sure.
So for any time a EKG is unstable,
Mhm.
you would always want to, I guess, do a cardioversion, because from what I was looking at, anytime like if it's unstable, you would do a cardioversion, and then once you're stable, or once an EKG is stable, for example, like atrial fibrillation, like you said, if it's unstable, you would want to do a cardioversion, and then once it's stable, you give like an anticoagulant or metoprolol, correct?
So fast rules are never great. They're a way to help you remember, but here we have a stable, and there's cardioversion if all else is ineffective, and that's under the stable. We had here with the PAC, there's no cardioversion here. So if you're going to remember cardioversion, I need you to find the ones that you cardiovert and lump them together, rather than say the general rule is if it's unstable, you cardiovert. Because
Okay.
we
Yeah.
have also defibrillation if it's unstable as well, right? We have giving adenosine or atropine, right? So there are different,
Yeah.
yeah. So
Okay.
Mhm.
Okay. I just wanted to clarify that because for what it sounded like, you would do cardioversion, so that's why I was a bit confused. But thank you for clarifying.
Sure. So if there's a pulse, we cardiovert. If there's no pulse, we defibrillate, right? But find the ones where we don't have the cardiovert, you give medications, right? So that's how I would, lump them together in order to remember which one is which. But good question. So that's the atrial fibrillation, and we're done with that. So for the atrial fibrillation, I would definitely remember the anticoagulation, right? That's important. Okay, let's see the next one. We have starting with, we just did this one. So where are we? Where's the next one? Oh, this one. Okay, so let's go into the ventricles. Oh, sorry, you had a question. He answered it. Okay, good. Ventricular arrhythmias now. So we remember atrial is bad, but ventricular is worse, right? And the reason why is because of where it affects, right? So I want to keep in mind, or you to keep in mind, the reason why is because it affects the lungs and the body, right? So we have PVC, so premature ventricular contraction. So we'll see QRST, a couple of them, and then we'll see one PVC that looks like a wide QRS wave, and that's what tells us it's a PVC, because we don't have a P here. It's affecting the QRS. It's just wide. So that's how we figure that out. If there's multiple ones of them, we have a risk of going into V-Tac. The treatment, we see monitor the patient. So there's no, they don't even mention stable, unstable, right? It's just usually monitored. We usually want to do something when it becomes too many, right? That's when we want to get them out of the rhythm, but usually anti-arrhythmic medication is enough, treating, changing lifestyles.
So isn't there like a 6-second delay that you use?
I said, like, if they stay within, if they happens for 6 seconds, we get them out the rhythm. Is that what you mean? What is this? What's 6 second mean?
I think I like read it.
No, that's okay. But what was it in reference to?
It said something about like if there's more than one PVC.
Okay.
And like,
Oh, in a
6
6 second strip. Okay. Or 6 minute strip. Is it 6 seconds or 6 minutes? 6 seconds. 6 seconds, sorry. Yeah, so if you see multiple one of them, then you know it's either bigeminy, trigeminy, and then that means it's going to lead to a V-Tac, right? So we don't want multiple ones in that EKG, in that 6 second strip. So that's the thing.
What you said, bigeminy, trigeminy?
Right, so bigeminy, can anyone remember what bigeminy means? Two. Bigeminy means 2 PVCs. Trigeminy means 3 PVCs. And then the more they increase, you just give them a number. So which means to us, if we see a few of them, then we want to be wary that they're going into V-Tac. Now we won't even see a P anymore. We won't see them. We're going to just see V-Tac if it keeps going that way. The more that it happens, the more possibility that it will just go into V-Tac. Yeah. So it's not like, oh, if there's 5 of them, it's going. We don't know. As long as we see more than one, then we're like, oh, we're afraid. We don't want it to get there, right? So it's just cautiousness.
After trigeminally, you would just say 4?
Yeah, however many you see, as long as there's as long as it goes back to the PQRS, you know that it's not a full-blown V-Tac. So then you count how many you see. Okay, so then we see V-Tac. So V-Tac is a huge issue, right? And what is the problem? The problem is the ventricles are not contracting properly, right? They're contracting too fast. They're not giving the atria time to let them fill up. So they're not going to send off the blood in the way that they should in order to perfuse the body. So we can't remain in V-Tac, okay? So the person will become unstable and we got to get them out of it. Let's see. So we're assessing the patient to see how they're feeling. We're checking to see if they have a pulse or no pulse. So if pulse is usually stable, no pulse is unstable, definitely unstable. Okay, so what we're looking at, the person might feel lightheaded, dizzy, have palpitations, fatigue. What we're doing, we're treating them if they're unstable. If they're stable and they have no signs and symptoms of anything, we're going to give them amiodarone and we're going to cardiovert them, right? And we're cardioverting them because they have a pulse. Remember, we said that. But that's if they're stable. So even if they're stable, right, this is another one, Moises, where if they're stable, we're still trying to get them out of it because this is V-Tac. So it depends on what it is, right? Some of them won't be as detrimental even if they have it, right? But some of them, even if they're stable, we just don't want them to remain there.
So for V-Tac, it's you would still give amiodarone?
Yep. If they're stable, you'll give the amiodarone. If
Can you also, oh, okay. But can you also give them lidocaine too?
I'm not sure about that.
Because I was reading in the book, and that's why it was kind of confusing me because like in the PowerPoint, it said you can give, you give amiodarone, but in the book, it said you can also give IV lidocaine.
So if the book says it, then that is
it's a possible, okay.
Yeah. So what is given the most is the amiodarone, and that's why I have put that there. But if the book stated that, then definitely go ahead, Andrew.
Okay.
So the treatment, you'll give both.
Yeah. So you would give them the amiodarone first in order to try to get them out of the rhythm. And then if that doesn't work, then you would do the cardioversion and you would do the cardioversion. So if the amiodarone works, then we don't need to cardiovert them. But if it doesn't work, then we're going to cardiovert them.
So cardioversion is just the last resort if amiodarone is, if everything else is ineffective.
Yeah, yeah. Because if the amiodarone worked, then we don't need it. Yeah. I'm not, I can't really say how long, like I'm not sure, but if they're not coming out of it in a matter of minutes or so, like, because I would say anything 6, like you don't want to get to the point where the signs are going to become so, detrimental where you're like, okay, they're not perfusing properly. So using your judgment, I guess. That's all I could say, because I don't know, like there's a set time, or if there is, I don't know of it. Okay, moving on. So then we have ventricular fibrillation. So with the fibrillation, just like with AFib and atrial flutter, we have ventricular fibrillation is worse than ventricular tachycardia. And so with the fibrillation, we have the coarse, we have the fine. We said the coarse means they recently got into this rhythm and they have better chance of getting out of it because we can still see some electrical activity there. With the fine ones, it's harder because as you can tell, it's going kind of, looks like asystole almost, right? So it's harder to get them out of that rhythm and more dangerous if they get to that point. So we're assessing the patient, we're defibrillating, right? As you see, we're not cardioverting here. There's hardly any pulse because you don't see a P, you don't see a QRS, you don't see hardly anything, you just see zigzags, right? So we're defibrillating them. And that's whether it's coarse, whether it's fine, okay?
The treatment is just
Defibrillation, yeah. If you're defibrillating, that means it is shockable, right? The only time that it will try to get to, it will give a charge in order to get them out of it is if it detected a place to send the shock. Yeah. So if it doesn't detect it, it'll tell you no shock advised because it can't find a place to shock them because it realizes there's no impulse, stimuli, or whatever we call it. So we can see with the fine one, Francis, right? With the fine, it can tell us no shock advised, even though we know it needs it. The person's looked like they're dying on us, but because it's so fine, it can't find.
That's what I was just like wondering about, because it's like the V-Tac is like so fine.
It might, and that's why I said it's harder to get them out of that rhythm.
Okay, that makes sense.
Yeah. So, but the coarse one, they stand a better chance. You're still going to place the defibrillator, right? Because you don't know what's happening. The defibrillator is what's checking the EKG rhythms, you know, to see what's happening, right? So as soon as we see the person has a heart issue, we're placing the defibrillator, right? We're like, you know, get the defibrillator and we're starting CPR. We don't know what the heart's doing. We're doing whatever we need to do. Now, once we bring the defibrillator, it will monitor the rhythm, check and say, sorry, no shock advised. See? Okay, so then we have asystole, which is very close to what we just saw with the fine, where it's a pulseless electrical activity. We can't do anything. There's no pulse. There's no electricity going into the heart. It's not going to beat no matter how much electrical shock you give it. So it's just not going to give it any. Okay. So let's see. Oh, sorry, guys. Go ahead.
What part does the ventricular shock on here?
It shocks on the R wave. It doesn't shock on the T wave. So really quickly, for the pacemaker now, right? We want to make sure we understand there's capturing and there's times where it doesn't capture. So when we see a spike, that means the pacemaker was activated. It sends a signal, it sends a shock, it sends a stimuli. It's working as the SA node would, or the AV node would, by sending the signal. And if we then see a rhythm, that means the heart picked up the stimuli and it stimulated or produced a rhythm, right? So it can be A pace or V pace. A pace means atrial pace, it's pacing the atria because something's wrong with the atria, or V pace is pacing the ventricle because something's wrong with the ventricle. And then we have the AV blocks, which good to know. I'm not gonna test you on that. I could tell you that flat out. Just know that there's a dissociation between the atria and the ventricle. One beats on its own, the other one beats when it wants to, and they don't connect, which they should. And that's about that. So for you online, I'm gonna come off and come back on because the time frame is limited. So if it signals off, I'll come right back on. Actually, I'm not gonna come off. You just let it get off and then I'll turn it back on. Next we have hypertension. So with hypertension, we're thinking about the purpose of blood flow, how it's pumped through the system, through the body. We talked about the hydrostatic, the oncotic pressure, all of those pressures. The point was we need our blood vessels to be smooth and effective as they allow blood to flow down, right? So we don't want it to be too strained. So with the pressure, if it's too high, it's going to strain the vessels. It's going to cause the blood vessels to be ruined, and that's going to affect how blood gets from one extremity to the next. So we want to reduce the blood pressure, keep it at a minimum level. Knowing that, the systolic and the diastolic, we worry more about the diastolic, but that's good to know information. Understanding what can cause the blood pressure to go up or down is important, because then you can understand if there's a problem, what we're going to affect, what we're going to either give medications for. And so the viscosity, the length, the diameter, and the things that will affect it is the oh my gosh, I can't remember. The kidneys, the brain, the pituitary gland, hormones with BNP, those kind of things. So remembering that, that's good to know information. Primary versus secondary, also good to know. Hypertensive crisis, you must know about that. Oh, remember, you must always know about anything that is complication that'll kill you, right? Hypertensive crisis will kill you. Okay, because it means that there's damage to organs, right? And what organs are we talking about? We're talking about the brain, we're talking about the kidney, we're talking about the eyes, right? So the cardiac, the nerves, all of these things can be damaged. And once we have hypertensive crisis, remembering that this is a silent killer, so we don't even know it's happening until it happens, right? So you won't have any symptoms until you have organ damage, then you'll have symptoms. Okay, so blurred vision happens when the retina is damaged. Kidney failure happens when the kidneys are damaged, right? The arteries in those organs are damaged. So we want to be careful and monitor those things. It'll affect the brain where the person's losing consciousness. It'll affect the legs, they can't walk. All of these things are going to be affected. Remembering the risk factors, they all make sense, right? When we think about what affects blood flow, right? What affects blood, like diabetes affects blood flow, of eating and your nutrients, too much salt affects blood flow, your obesity, or all of these things affect it. So just remember that. Things that you can't control, your genetics, your age, your race. Remember, we said African Americans are the ones who are more prone, can't change that. You must know those information. Nursing intervention. Once we know the problem, what are we going to do, right? If it's a hypertension issue, we're going to decrease the hypertension. We're going to bring it down. We're going to give them medication to lower that. If they have vision issues, we're going to tell them to go check their eyes. If they have kidney issues, they have to go check their kidney, right? Whatever the symptoms are, once it's damaged, we're going to have to just monitor the symptoms. But before it happens, we want to prevent it, right? So we're going to do prophylactic things with weight and diet and exercising, things like that. Checking the blood pressure routinely. For medications, you have to remember the medications that we use, like thiazides, loop diuretics. And remember, of all the ones, well, actually they all are important, but the ones that they use the most are the loop diuretics and the thiazides, because they reduce the amount of fluid. Because once you start having blood pressure, it starts to affect your heart, and then it starts to damage the heart, and now it's not pumping properly, and now you're having backup, and then you're having edema. And so in order to help reduce the stress and the strain on the heart, we give diuretics. But it's also important to control the contractions, right? And to help the heart contract properly. So remembering what these are, I gave examples. So if you can remember other examples, great. But if you can remember my examples, and usually, the endings will help you remember which kinds they're connected to. So definitely remember that. Problems related to lifestyle changes. We talked about this already. And that's that. And let's get to the last one, which is the peripheral vascular. So peripheral vascular, very much connected to just the idea behind what makes the vessels work properly, right? We said for PAD, it's the arteries. So when we have artery issues, it's more like the clotting, the occlusion, the plaque formation. That's what's causing the problem, right? And then when we know the function, it brings it away from the heart. And what is it bringing? Oxygenated blood, nutrient-rich blood. So anything that needs that doesn't get it is going to have a problem, right? And so since it's a peripheral issues, it's going to be the legs, it's going to be the fingers, it's going to be the toes. So what do you need? Blood, oxygen, red blood cells, white, but what do you need those for, right? You need them for healing, for nutrition issue. Like if you can't get those things where they need to go, you're going to have problems concerning them. So just think about what it means rather than memorizing what it's doing, right? So with the venous issue, it's the vein. And how does a vein work? Well, the valves. So when the valves are not working properly, they're not closing all the way to eject the blood up to the heart, then there's stasis. It's going to sit back. It's going to stay behind, and it's going to start swelling up. And then you have varicose veins. If you can identify one thing that you will remember and understand to that issue, you'll remember it all, right? So with the varicose veins, we can visually remember what a varicose vein looked like. So if we can understand that, and therefore we'll remember what's wrong, right? And for the arteries, I tell people to remember the intermittent claudication. Like if you can remember that one and kind of put that to not just memory, but understand it, then you'll be able to understand any other issues that has to do with the arteries, right? Go ahead, Andrew. No, so arterial issues, we think of atherosclerosis, right? There's plaque, which is the fat buildup that's being created in the lining of the artery. And because of that, as it builds, it grows and it closes the gap in between where the blood is supposed to be flowing, because it's happening within the lining, right? So that's the occlusion that's happening. So it's not blood clots, that's, it's the plaque that's building. So now, obviously, if it cracks because of strain or stress or whatever, then we're going to form clots and other issues that's going to cause more blockage. So when you think of arteries, you think of, whatever she's showing. Go ahead.
Is that kind of similar to CAD?
Yes.